All right. Now we don't have echo. What are you looking up?
American College of Cardiology. Economic impact of false STEMI cardiac catheterization laboratory activations at major Los Angeles County STEMI receiving centers.
Is it that bad? Is it devastating?
I'm looking for per
Economically
episode,
speaking?
but it cost $187,643.45 per year for falsely activating the cath lab team. It's also detrimental to team morale.
Detrimental to team morale? Just being overly cautious or what?
I think from waking up in the middle of the night, driving to the hospital to be canceled, and then drive home.
Who fucking knew? That's like all of our calls.
It's not EMS team morale. I think it's
right.
nursing team morale.
I see. All right.
Are we live?
Yes.
Nice.
I just was went into it, and we'll see how it goes. You can always edit the beginning out if you want, but
No, definitely. First
episode of
First
Holding the
official.
Wall. We're down one person, Mike. He had some important business to tend to, but he'll be meeting us back for the next episode.
That's right.
So this one, like we mentioned in our intro, is going to be about STEMIs, or ST segment elevated myocardial infarctions. Kind of a mouthful, but honestly, this is kind of stemmed for me. I brought it up to these guys for I ran a STEMI the other day, and as we're sitting outside, cleaning up the gurney, doing some paperwork, one of the doctors had a med student, and she was like, "Oh, do you see any reciprocal changes?" And he had this blank stare on his face, and she was like, "Do you remember what reciprocal changes are?" And he said no, which is fine. He's a med student. They're learning. There's some people don't have a lot of EMS experience or that stuff. And her explanation to what reciprocal changes were was so horrendous. Coming from the ER physician, experienced ER physician, I was just like, all right, this would be a good first episode. So kind of just brush off some of the cobwebs for a lot of people who are in this field, who kind of take all this stuff for granted. But it was like, reciprocal changes are, the reciprocal of the ST segment elevation, So it's just, that's why it's called reciprocal change. I was like, you can't use the word in the definition.
Yeah.
All right, lady.
It's the thing.
Jesus.
Because of the thing.
Yeah. It was terrible. So you guys were pretty receptive to it. But is there anything you've seen recently that kind of stuck out for you for STEMIs, or in your experience that kind of threw you for a loop, or anything like that, especially in the emergency room?
Well, I'm a little rusty on my EKG leading, especially after becoming a nurse. It's more of a team approach, and I'm not the lead provider on this. But I've been seeing a lot of presentations of just atypical signs of chest pain. A lot of the STEMIs that we're receiving at the ER I work with, which is also a STEMI center, it's a lot of acid reflux. Acid reflux presentation, patient does not associate the epigastric pain with chest pain. I've had flu-like symptoms for 3 days. And then turns out, that they're having a huge STEMI.
Oh, really?
Yeah.
In those patients, have they been a lot of diabetics? Because in my experience, there are a lot of the diabetics like, oh, I think I'm coming down with the flu. I just feel really crappy, generalized weakness. Those random kind of atypical symptoms have always been the diabetics for me.
The handful patients that I encountered, it wasn't my primary patient, so I was just there to provide extra resource of starting the line, getting the patient prepped for the cath lab team. So I kind of want to backtrack a little bit. I think we should talk about the STEMI from an EMS provider standpoint, and then I could probably take over once they get to the ER, so that I can put some.
So from start to finish, it was kind of a rough chest pain call. We showed up secondary to our first in truck, and we just get it. Hey, we're getting our 12 lead back. It's looking like a STEMI. This patient's going to have a sudden acute onset chest pain. And we pretty much, it's like a load up and go situation, which I hate doing. There's assessments and there's care to be provided on scene. Granted, the time isn't a matter, an issue, but we can initially get some stuff on it, get a history, allergies, and meds at bare minimum, right? Well, they say there's nothing really going on. The firefighter gives me a pass down, so we bring him to the ambulance and we start doing our care from there. We asked the patient about nitrates. or excuse me, not nitrates, but
Sexual enhancing.
phosphodiesterase inhibitors. Yeah, and he didn't mention anything about him. He's like, no. But apparently, the wife told the other firefighter on scene that he had taken Levitra. So during my pass down to the nurse, I say, we gave 3 sprays of nitro, no relief. And he's like, why'd you give nitro? I told you that there was a sexually enhancing drugs. I was like, nobody told me anything about that. The patient didn't tell me that. You didn't tell me that. He was like, whoops, I meant to. I'm like, I'm going to fucking kill you. I was so mad. I was so frustrated. So I had to go back in there and be like, hey, sorry, my partner just told me about these PD5s just now after our initial care. So just so you know that happened. And then you hear from the doctor and she's like, this is a beautiful EKG, and then the explanation of reciprocal changes. There was just a couple of things that I was like, oh, sweet Jesus. Like, we need to kind of hone in these chest pain STEMI calls and make them be a little more proficient at them. It was super frustrating. But for us, yeah, it's, especially in my county, it's the typical 324 aspirin, nitro, morphine, and then we can do nitro paste as well, and then our 12 leads. That's pretty much the gist.
Awesome. Do you know what the outcome of that patient was, or?
Yeah, he went straight to cath lab, and he was good after that.
Got it. So from an ER perspective, at least in the county that I operate in, one of the first things they're going to do is repeat the 12 lead. I haven't gotten as to why. I wonder if the hospital 12 lead machine is more sensitive to filtering out artifact and stuff like that. But they're definitely going to repeat the 12 lead. If you call it in the field, they're already going to have the cardiologist on standby. If it is a paramedic activation, then the cath lab team that is on call will be en route to the hospital. They have about a 30-minute, I believe it's a 30-minute shoot time to get it to the facility and open up the cath lab. So there's a lot of things going on the ER side. You want preferably 2 lines because it is going to be a surgical procedure, cardiac catheterization. So you want at least 18 or 20 in an AC for a surgical procedure. So if that was something that EMS couldn't obtain or they only had 1 line, we're going to get a 2nd line. Depending on your facility, they're probably going to shave the patient's perineal area for the femoral stick. Yeah. And then just other procedures, putting on defib pads and stuff, which is just all like procedural stuff for the cath lab team.
It's funny you should mention the second 12 lead. We did I did a couple en route, and we gave our nitro, our ST segment elevation went down a little bit, and so by the time they got to the ER and they did theirs, it wasn't showing anything. So that's the whole point of nitrates, to open them up and hopefully get rid of that elevation. And the doctor was like, okay, we'll be able to show them theirs, and that will be good enough for our STEMI activation. But then the preceding ones actually don't even qualify for our STEMI activation. But that's fine because we have our initial one, and that was going to be from us. So that actually ended up being pretty good.
Yeah. So I think that's a good place to say that the importance of a field activation, because we've had a few times where our local EMS service, they're on the fence about calling it STEMI. They didn't provide a good radio report. Yeah. So then the ER physician wasn't sure themselves to call it because it, like I said in the intro,
that picture,
that cost, right? So then they show up and they do a repeat, and it is a STEMI, and then now the clock starts there, right? So now, time is tissue. So now from ER presentation, now you have a 30-minute shoot time for the team to get there. Mm-hmm. And then most of the times you're ready for the cath lab team in like 10 to 12 minutes. And then now you're just kind of sitting on this patient, making them comfortable, continuing that MONA acronym until the cath lab team gets up.
Are you doing nitro infusions?
I haven't at my ER. Yeah. But I mean, that's not uncommon. Or they'll do heparin maybe, depending on the cardiologist. Okay. They'll do like a heparin bolus or something like that.
Yeah, I think I overheard them say they give their initial heparin bolus for this last guy. Nice. I also wanted to just bring up some of the like, minor things that you kind of forget about in high school, or not high school.
Feels that long ago.
I know, it really does. It's about that long ago. Medic school, nursing school, all your education process, like the 5 imposters. Could you even name those right now?
Barely, but I'm going to caveat this. We don't go in through EKG or 12 lead recognition in nursing school. So a lot of the stuff that I carried over was from medic school.
Oh, really?
So I mean, if we want to get off on a side tangent, a lot of the nursing school stuff, as I saw it going through it, was it's entry level. It's going to make you an entry level competent med surg nurse. Depending on the facility, that's just your entry level nurse at a BLS provider level. When you get into the more specialized units, telemetry, ICU, step down, ER, then you'll need ACLS, then you'll need PALS, then you'll probably need some type of 12 lead EKG class. Okay. But those are usually like 8-week crash courses, or something that like a West Coast CMT or a Surefire type of facility would teach.
Yeah.
So yeah, a lot of the stuff is piggybacking
that's,
from medic stuff.
That's a good point, because in my experience of teaching ACLS and PALS, and I taught at all the nursing schools. I taught your sister ACLS.
Oh yeah.
And their knowledge of EKGs is pretty minimal. Most of what they got from about EKGs was taught in our class, our ACLS class. The rhythm identification, how to analyze rhythms, was like primarily taught in one day while we were there. And then 12 lead wasn't even touched.
No.
Wasn't even touched. Like you know how to place the 12 leads, and then you take that slip and you hand that to that doctor, and he'll analyze and he'll read the top and all that stuff. So
actually, I remember my critical care course in nursing school, and it was just like one lecture on one day, and it was just like, this is a P wave, this is a QRS, and this is a T wave, and what they correlate to, and that was it.
That's crazy. I mean, think about how long our cardiology section was in paramedic school. It was
like
4 or 5 months, and every other day kind of thing.
Right.
So it's pretty wild to think that.
Anyways, 5 imposters.
Oh yeah.
Was it 5 or 7?
It's 5.
Is it 5?
Yeah.
All right.
So, I'm curious.
Let's see. Pericarditis.
Good.
Bundle branch blocks, but I think it was
Which
right-sided. No, wait.
The other one.
Left-sided?
Yeah.
Left-sided bundle branch blocks. BER, which is benign early repolarization.
Good.
Yep,
that's 3.
Up to 3. What am I missing?
LVH.
Oh, yeah, that's right. Left ventricular hypertrophy.
And ventricular paste.
Okay, yeah.
So.
But see, elevation occurred to me because you're looking at these long QRS complexes on your V leads, so I mean, you already know that.
But
that's true.
You have to remember concordance and discordance.
Right.
So with the LVH, because you're seeing such negative QRS complexes that are so deep, that you're going to see that concordance in the T wave that's really big and peaked. So when you start like trying to discern, is this LVH or is this actual STEMI, you need to look at the concordance or discordance in the T wave. So if you have like V1, V2, and you see a negative QRS complex with a negative big T wave, that's going to be a STEMI compared to the discordance of a big, steep negative QRS complex with a big, large, positive T wave. Does that make sense?
A little bit. I was always touch and go with that stuff. And the other thing that I had to admit, but that I never really internalized, that I always...
What the fuck is discordance?
That and Scarbosa's criteria. Do you remember Scarbosa's criteria?
All means.
No, see, I don't. It had to do with concordance and discordance, but it's how to predict STEMIs and left bundle branch blocks.
So...
And I don't...
Healthy hearts have concordance. So the QRS complex is going to point in the same direction as the T wave. Discordance, that's unhealthy, and that's going to be, you're going to see that in LVH. So you're going to have discordance in LVH, and then in healthy hearts, you're going to have concordance. But you also have concordance when it has a STEMI as well. So if you see LVH and there's concordance, that is actually a sign that it might be some ischemia or infarction.
Got it.
And then I looked up a bunch of this stuff today. Don't even trip.
Yeah, I know.
I was like, man, I need to brush up on this. Reading some articles. Benign early repolarization, that's kind of just basic. Yeah. That's just young people, healthy hearts.
Yep.
Might see a little bit of elevation, but most likely, more than not, they're not going to be coming in for chest pain. They're not going to be complaining of something significant that even warrants a 12 lead. So it's very unlikely that you're going to even see a patient with BER anyway.
You might not totally them in the field, but I noticed that I feel like it's that litigious society and the CYA that we 12 lead everybody in the ER with some type of.
What's the qualifiers for that?
They come in tachycardic, chest pain, abdominal pain, generalized weakness,
Even if
flu-like
they're like
symptoms.
22?
Even if they're 12 days old.
Oh, really?
I had a case that because the patient was tachycardic at 12 days old, which is normal, that the physician ordered a 12 lead.
Oh, for fuck's sake.
I think it's just that CYA society that we live in. So,
well, there you go. Usually you won't see it in patients under 40.
Right.
I actually learned that it's predominantly in African Americans. So young African American, they have a tendency to not complain about those are the patients with BER. There's a study that showed that those particular patients were less likely to complain or get seen for significant injuries or illnesses. So you're very seldom going to see BER anyway. So that's kind of interesting, unless you're at your hospital, I guess. Left bundle branch block.
yeah.
Yeah. You know, you're going to see a wide QRS complex in every lead. You know, that's going to be the big sign. You're going to look at that V1, V2.
Yeah. But you know what's funny is I remember something out of context. There's two things I want to bring up that this just goes back to medic school, like stuff I didn't touch in nursing school. But there's something about, was it chest pain with new onset left bundle branch block? That would be a high indication. But then how would you know in the field?
If it was new or not?
Yeah. Because I always thought about, I was reading that, I'd be like, how are you going to know in the field? Unless that guy had his, like,
His
12 lead.
This is my old 12
Yeah,
lead.
yeah, I
This
was
is part
just
of my
at-
paperwork.
I was just
This
at the
isn't
doctor's
Lynch.
shit.
They don't have the paperwork. That's for us. We're not, unless you just happen to have one of those really anal patients who does have their whole list of all their medical history in just a little packet ready to go. There's occasion like we get these repeat patients that you just know so well that you would recognize a difference in their
Yeah.
all of a sudden they're always normal sinus and nothing in particular, and all of a sudden they went into something like that. There was a patient in our city who the hospital had to write a protocol for her because anytime she'd get a 12 lead, it would always read acute STEMI. So every single time they ran on her, they couldn't, and she always complained of chest pain. So there's no way for them to rule it out. So they always had to treat chest pain. When they got to the hospital, they always had to go after. You should just call like 2-3 times a day, every day,
Dang.
a day, every day. And the hospital got to the point where like, nope, not doing it. So it was like I don't know her name, like the Jane protocol. So like as soon as she came in with first STEMI, nope, we're not going to deal with it. Check her troponin and send her home.
There you go.
That was it.
Yeah.
Yeah, it was pretty funny.
So hold on. The second thing I want to touch up on, which is, I don't know why I held on to it so long since school, but do you remember the proper position for a 12 lead obviously is supine in like anatomic position. Do you remember how many millimeters your ST segment could change just by going from seated to supine?
No.
Yeah, I know. I don't know why I held on to it for this so long. So if you do a 12 lead in a seated position and then you repeat it in a supine position on the same patient, your ST segment could change up to 3 millimeters, which is huge.
That's crazy.
Because you only need 1 millimeter in two contiguous leagues to call a STEMI.
Yeah.
So, I remember that was one of the things that I always made a pearl about when I was teaching like 12 lead to somebody. It was like, always try to get it in supine as you can. Because
Always. Interesting, yeah. I honestly did not know that.
Yeah, I don't know why I held on for that so long.
So, yeah, I'm going to have to start implementing
3
that at work.
millimeters. I was like, damn, that's the difference
Somebody
between...
starts complaining chest pain, 12 lead, like, let's get them on the gurney and we'll lay him flat, see what happens. That's pretty wild. What was your first STEMI that you ran? Can you reach back to that brand new paramedic?
My first STEMI. Sounds like a toy. Like your first chemistry set or something.
I distinctly remember mine.
I don't remember if it was a STEMI though, but I remember like, I'm pretty sure it was. Hold on, I'm thinking back. Man, that's like 7 years ago.
I still remember mine. It was during like my preceptorship.
Yeah, I think. Okay, so I'm pretty sure this was mine. I hope I'm not confusing two stories into one, but it was second to last shift on preceptorship. I was with AMR. It came out as chest pain, and I'm pretty sure they were level 0 that night because I remember we had like a 12 to 15 minute roll time. Code 3, by the way. We show up and this woman was fairly huggable, I guess. Look,
that was the most PC way of saying fat I've ever heard.
Well, yeah, but I mean, I remember. I don't remember the dispatch information, but I remember we were joking that it could just be like anxiety or HP, if everybody's privy to that term.
We'll leave it for the.
It was weird because it was like that towards the end of preceptorship where you felt confident and you kind of had that ego about you that you're like, okay, I'm finally internalizing this. I finally know what I'm doing right. So we show up and I start asking, whatever my spiel was as a student, right? Hi, my name is Ryan. I'm a paramedic student. What's going on today? Yada, yada, yada. And then unsolicited by me as I go through my assessment, she's like, yeah, it's in the center of the chest. It feels like an elephant sitting on me. And then I was just like, you can't make that up. That came right out of the book. And I was like, does it go anywhere? And she's like, it goes to my left arm.
What did you go to?
Yeah. And then it goes to my left arm. And I was like, oh, okay. So we do a 12 lead and it just says normal sinus rhythm. And, whatever I muscled memory into my head, oxygen, whatever. And I just remember we were trying to move her to we were moving her to the gurney, stand and pivot, because at this point, other than her symptoms, every assessment tool, BP, 12 lead, EKG, everything was unremarkable.
Yeah.
So we get her up to stand and pivot, and she just goes unresponsive, snoring respirations.
Whoops.
And then I remember I was like, what's on the monitor? And the EMT's like, oh, I took her off to stand and pivot her. I was like, put her back on right now. And it was VFib.
Oh, shit.
Yeah. So it was VFib, and I remember the squad, the squaddy who started compressions, and we got the pads on, we charged, we defibrillated right there in the patient's living room, and then she came back to a sinus rhythm. Asked for a repeat 12 lead. I'm pretty sure we did 3 en route on top of aspirin. I think we gave aspirin, and I started a line.
Yeah.
And I remember she came back after that first one. She's like, oh, my God, what happened? And she's crying and hysterical. And then she's like, my chest hurts. And I was like, yeah, we did compressions on you. Yeah, exactly. And then I just remember we get to I almost said the name of the hospital. But
yeah, say it.
Yeah, fuck it. All right, so we get to RCH. And they do a repeat 12 lead.
30,000 signing bonus.
Yeah, that's right. That's right. Hey, for all you 3-year plus nurses there.
Yeah, right.
Yeah. $32 sign-on bonus. Anyways. So they do a repeat 12 lead, and it's a normal sinus as well. And then we're talking about the call. Me and my preceptor are debriefing, right? So that I could, learn from this, internalize it. And we're there for about 20 minutes, and they do another one. And then she has I'm pretty sure 3 or 5 millimeters of elevation in 2-3 AVF. Because I remember the EMT that was doing the 12 lead went out of his way to tell us that, look, now we're activating the cath lab team. And it was just, I'm pretty sure that was my first STEMI.
Yeah.
But they didn't come out as a STEMI.
Sounds typically like the shit show that we come across.
Yeah.
And especially as new paramedics, especially going through school, you just get thrown these curveballs that you're just not expecting at all.
Yeah.
Yeah, I think mine was in Hemet when I was doing my second part of my preceptorship. Again, textbook, just like yours. Where it was woke up 3 a.m. all of a sudden having super acute substernal chest pain, radiating to the left arm. Everything was check. Did a 12 lead. Didn't even put him on the 12 lead at first. Just saw this huge tombstone T, having inferior wall MI. And we were able to give aspirin. We gave a little morphine because we couldn't give our nitrates. And then I think it was Uzi from paramedic school. Like another student came in.
He showed up on the...
And my preceptor shoved him outside. He's like, nope, he's got this. And I kept going with my call, and then we ended up flying the guy out because we were in the middle of bumfuck nowhere, and he had to get to a STEMI center as quick as possible. But I don't know why that stuck out to me so much, because he had that cool pale diaphoretic sense of impending doom, all that stuff. And I was like, man, this guy's really just checking all the boxes for this legit STEMI. And for some reason that always stuck out to me.
Dang. And it was okay. So then their closest probably would have been RCRMC.
Yeah, I think so. Which was 40 minutes, 45 minutes.
I know it's far, but I never worked out there, so that definitely warranted a fly out. You couldn't.
If you're on meth, which most of the people who live in that city are, they probably drive like 150 miles an hour. They probably could have made it there just fine. But yeah.
My last STEMI when I was in the field was meth induced.
That's not surprising.
That was an interesting one. So
yeah, I don't know why I researched this, but that's the crazy thing about like blow and meth. Like it's like the trifecta of artery occlusion. It's vasoconstriction,
right?
Tachycardia, so increased myocardial oxygen demand, and platelet aggregation. Like all three of them occur because of those drugs. So it's just like, oh, if you're over 40 years old and you're doing any of those drugs, you're just a ticking time bomb at that point. You're just waiting to have some kind of stroke or MI.
That's I don't know about the rest of or like your coverage area and stuff, but for definitely my ER, that there is definitely a meth epidemic in my area, which from the ER I came from used to be a heroin epidemic, but here it's meth.
Really?
Yeah. So a lot of people come in for chest pain, or they're methed out and stuff like that.
Me, our area, booze and heroin. That is it. Like
booze and heroin.
Booze and heroin.
Yeah.
We had a guy the other day who was outside, according to our truck. They drove by on several calls, and he was outside drinking 40s all day until we ran on him at 8 p.m. At which point he got in a fight with 6 cops, got tased 3 times, and then thrown to the ground and got knocked out. I was like, cool. All right. Well, he's going to be easy transport. He's
6 times.
So a couple other things that I wanted to mention was just like there's things we learned in school, which I'm sure even now, 7 years later, we're a little outdated. But I remember I was doing this lady had a completely benign, like my hands feel tingly kind of like call.
Mm-hmm.
And I was like, she has cardiac history. I'll just do a 12 lead, just kind of cover my bases.
Yeah.
Sure enough, she's having a STEMI, inferior wall. So I was like, okay, well, let's do a right-sided. And my captain, it was when I just started probation, and my captain looks over at one of the other medics and he's like, "Is that normal to do a right-sided?" And my firefighter's like, "Yeah, it's just something we do. Don't worry about it."
Yeah.
And some of these outdated guys just don't know. Like some of these like firefighters or even older paramedics, they didn't have 12 leads when they started. They had a basic 4 lead with a little screen, by like a 2x2.
Yeah.
And he had no idea what I was doing. He's like, I didn't know right-sided 12 leads were a thing. And then
they had the life pack, whatever single digit number with the
Life Pack
gel.
1,
yeah,
exactly. They love their paddles.
Yeah.
They still talk about it to this day. So I just wanted to mention like what right-sided 12 leads are, what's indicated, and then posterior wall MI are 12 leads as well. So for anybody who hasn't heard, perfect example. While working at Lynch, we went to Placentia for just a transfer, and this guy was having legit STEMI. They checked him out. It was inferior wall. So while I was getting a report from this nurse, I was like, "Did you guys do a right-sided?" She's like, "No, we do standard 12 leads here." I was like, "Okay, well, let's just get him going because he can need to go to a cardiac center where he belongs."
Yeah,
because I'm not going to sit here and argue with you. So on the way, I did a right side, and sure enough, he was having a right side 12 or STEMI, and they'd already given nitrate, so I held off and I just gave him some fentanyl instead for the pain control because this guy was straight tripping out. But it was so shocking to me that so many people, even younger personnel who work, again, you mentioned this with the nursing, they probably don't have that understanding of 12 leads.
Right.
But if you have an inferior wall MI, that indicates checking a right-sided 12 lead. Okay. So just take V4R, move it over to the right side.
Take V4, move it over to the right side, label
V4,
it V4R.
There you go.
There you go.
Hey, I misspoke. I have like 3 beers on board, okay? For anybody who's listening, we usually typically every single time we film this or record this, drink heavily. So
Right. Get the creative juices flowing.
exactly. So you take V4, move it over to the right side, label it V4R. If you have elevation in that, then it warrants taking a full right-sided 12 lead. Take V4, 5, and 6. Take it off, put it on your right side, and then run another one. See how serious that right-sided STEMI actually is. So, and then you also want to do posterior wall MIs or 12 leads if or you have other signs. Like if you want to talk about that.
Yeah, so you're looking at if you're starting to see elevation in 5 and 6, it'd be prudent to do a posterior 12 lead, or if you're seeing depression, reciprocal changes in V1, V2.
Yeah. Yeah, V1, V2, sometimes I hear V1 through V3. Yeah, anytime you see those like that depression, that was reciprocal changes, the reciprocal.
The reciprocal, yeah.
Because they're reciprocal. Reciprocal means like it's essentially the opposite. So the elevation that you'd see in certain leads, if you see from the opposite view of the positive lead, you're going to see the opposite of that, which is depression rather than elevation. So those reciprocal changes are kind of like the opposite view of the elevation that you're seeing.
Right. So if you're seeing reciprocal changes,
we're talking shit on it, then we never explained it.
If you're seeing reciprocal changes in V1, V2, that's like the septal part of the heart. It's indicative or prudent of you to do a posterior 12 lead because the elevation is probably in the backside of the heart.
Yeah, standard 12 lead never even looks at that posterior portion of the left ventricle, so that definitely warrants saying.
It also depends on your, I feel like your protocols, how progressive or aggressive, if that's the right adjective.
Yeah, I definitely, for EMS, we definitely talk about being an aggressive medics and taking those extra steps.
My little short stint in Vegas, in Clark County, it's almost standard protocol for any 12 lead and you suspect right-sided involvement. They're going to do a full right-sided 12 lead. They don't want you just moving the V4 lead. They want you to do a full right-sided 12 lead. And then on top of that, if you suspect posterior involvement, you're going to do
full 789.
Yeah, which is what 20 lead EKG or something, because it goes 6, 7, 8, 9, and whichever.
Yeah. So for people who don't know what we're talking about, you take 4, 5, 6 off. You're going to put it over on that left side, just below the scapula in a straight line, turning into 7, 8, 9.
Yeah,
and that'll give you that nice posterior wall view.
So it's not uncommon out in Clark County that they do that.
That's good. I feel like our Southern California EMS is just so antiquated in a lot of their views that we need to start moving toward those things a little more aggressively, like you said.
Yeah, but I just feel like with short transport times and especially in like LA County, there's a hospital
on every corner.
Yeah. Like a Starbucks. I feel like we're limited. Our protocols are limited because there's a lot of those, what do you call it? Not high risk, but low frequency skills. So,
just like, we don't trust you, LA guys.
It's protocol driven.
So, I sent Ryan a nice podcast I was listening to. It kind of gave me some things to think about. Then he didn't listen to it, so I'm just going to explain it to him.
Yeah, great.
If anybody wants to listen to it, it's the EM Crit podcast. They talk about the OMI manifesto. It's really interesting as far as the potential view of how we diagnose STEMIs and ACS and all that stuff. So what they're trying to move toward is not STEMI, but OMI. So an occlusive myocardial infarction rather than ST segment elevation myocardial infarction. And the reason for that is there's a lot of these end STEMIs, particularly of the right circumflex, that we're missing because they don't have elevation. And then these patients are going hours, if not days, in the hospital before they actually catch these occlusions. So something that they're looking for, which I've never learned, and it might be news to you, but the hyperacute T waves. So you might see a normal sinus rhythm, but you'll see these, it's almost like hyperkalemia, but you'll see these hyperacute T waves in all the leads, especially disproportionate to your QRS complex. So if you have a little, 5 millimeter QRS complex, and all of a sudden you're seeing these 8, 10 millimeter T waves, that's a sign that might be hyperacute. And if you see those with a patient who's having chest pain, syncope, all these kind of different symptoms, you might want to start thinking this patient still might be having a myocardial infarction, but it's not meeting your STEMI criteria. So he's trying to make a shift toward that. And I thought that was actually kind of interesting because they're catching, they said 25% of non-STEMIs are occlusive. And we're like letting 25% of our patients, essentially, some of them.
And are they saying it's the right circumflex is where it's occluding and that's what's causing the end STEMI?
So it's 25% LAD, 25%.
It's okay.
There's the LAD, circumflex,
Uh-huh.
and then what's the other one?
I don't remember.
Left main, circumflex, LAD, and some other one. We're gonna
And yeah. We'll just dub over it.
Right, and then so 25% of the other arteries, but then 50% of the right circumflex are the ones that are the culprits for this missing these end STEMIs.
So I have two things to add on that. One was during clinicals, there was a ER physician at RCH that was saying that these end STEMIs could also be caused by the infarct being so deep in the myocardium that the 12 lead doesn't pick it up. And that his explanation was that 12 lead looks at the surface of the heart. And so if it's deep in the myocardium, it's not going to trigger any voltage changes that you could pick up with the 12 lead. And the whole reason that they don't activate for end STEMIs is because the mortality is lower. So they feel like they have a few more, I don't know if days was the right word that he said, but you could track the STEMI with serial troponin, which I'm going to get shit on from my nursing coworkers, but I'm pretty sure it's like Q6 hours. I think 4 or 6.
That's beyond me. So
yeah.
Hey,
so you're looking, you're trending your troponin levels because you want to see when it peaks or if it's elevating. That way, if it's an active infarct or if the peak of the infarct has happened and then you're trending it down. Or for a lot of people that come in with chest pains, lately it's almost a guaranteed observation admission because you're looking for 3 serial negative troponins and they could be discharged that it wasn't a cardiac event.
Yeah. So, what they're recommending is just moving faster on the troponins. And as soon as you get an elevated troponin, start considering some other, like, if you see these other signs, then just, don't hold off on the cath lab just because you don't want to have that negative morale to the cath lab for personnel,
I drove 30 minutes for
Oh, yeah, exactly. Oh, how dare they?
Yeah. The other thing I learned in Vegas during my FTO time, my preceptor was going through his CCTP training, critical care paramedic training, and he suspected that, or not suspected, but he said that he noticed that with end STEMIs, you have all your signs and symptoms, chest pain, maybe some nausea, vomiting, maybe diaphoresis, but your 12 leads coming out clean. If you see that the rhythm is Brady, like a sinus Brady rhythm, it could be a possible end STEMI. And he suspects that the bradycardic rhythm is like a protection mechanism for the heart.
To decrease myocardial oxygen demand.
Yeah.
Slowing down, like, hey.
So if you're seeing all the
slow you down, all right,
yeah.
bud? And then we're going to try to oxygenate as much as we can.
Yeah. So he said he didn't really quote from his CCT training, but he noticed in the past that a lot of end STEMIs that he's had have all the hallmark signs and symptoms of a STEMI, but that their 12 lead would be in like a sinus Brady rhythm. So he's like, you should have a higher index of suspicion.
It's one of those things that you want to keep in the back of your mind.
Yeah.
Hey, just in case.
Chest pain with a Brady rhythm could be an end STEMI.
So I don't know if you ever read anything different. You're like number 1 in our class during paramedic school, but
what a fucking lie.
AVR was always told to me, and when I talk to a lot of people, is the dead lead, right?
Oh, yeah.
AVR is always dead lead,
right.
means nothing, never look at it.
Yeah.
So when you get preparing for this podcast, I was looking at some stuff. And if there's elevation in AVR and depression in all the other leads, that is indicative of left main artery occlusion. And that affects your circumflex and your LAD. So that's one of those big ones that definitely always, I up to this point, I have not practiced this, looking at AVR and looking for elevation at AVR, because those depression and all the other leads with that is a big sign that's left main, and that patient's heart is not perfusing at all. And those patients typically go into VFib pretty quickly.
So elevation in AVR, but depression in every
other lead.
Okay.
That's like they were saying it's endocardium, diffuse endocardium ischemia. I was like, oh, that's pretty interesting.
Yeah.
Yeah, I'd never heard of that before. So I always looked at, it's deadly. Just make sure your leads are on properly. Which, if you don't know how to put a lead on, you're...
That's true, too. Lead placement matters.
Yeah, I this is one of those things I always taught in my EKG classes was, I had this brand new EMT, sweet as can be, but terrible at her job. And this lady was having like really bad chest pain and all the, like you're saying, all the signs of like a legit STEMI. And, I asked her to do my 12-year. I'm starting an IV and giving some aspirin, and it comes back normal signs for them. I'm like, that's kind of weird. Lift up the shirt, and I mean, these leads are all over the place. Like, there's a V1 over by the left shoulder and V2, and it's just a complete mess. So I rearrange real quick, run another 12 lead, and sure enough, it's coming back STEMI once I fixed it. So if your instincts are telling you, like, those little hairs on the back of your neck are standing up, like, this is a STEMI, 12 lead placement matters. So, the positioning, where those leads are, making sure those are in the intercostals, like, that stuff goes a long way. Like, if you make sure you do those little things, it pays out in the long run.
Also, just leaving on the 12 lead. So, I don't even know how to tangent into this, but like, so if you don't know, some of your EKG monitors, I don't know if Zoll does it, but I know LifePak, the LifePak 15s with their whatever updated STEMI recognition software. I feel like a lot of medics in the city and county I work in, after a negative 12 lead, they'll disconnect the V leads and then clean them up, right, for the next call. But if you leave it on, especially with LifePaks, if your first 12 lead is negative and then there's a change, it will automatically spit you out a new 12 lead.
Oh, really?
So, yeah.
Interesting.
I know for sure LifePak 15s do that.
Zoll does not, unfortunately.
Does not.
And that's why I prefer LifePak. Like,
yeah.
I had them at AMR, and I don't have them where I'm at now. And man, I really think there's a big difference between the LifePaks. They're just so much more user friendly, and the 12 leads are so much cleaner. I don't know. I definitely like my LifePaks, but
that's true. It's a little heavier, but
hey, we're firefighters. We're supposed to be able to carry some equipment. Okay.
All right.
But no, yeah, that's pretty standard. We just take them off. But during that little OMI Manifesto podcast, they showed, a 10-minute difference in the 12 lead from the peak in the T waves, the depression that was starting. It didn't meet STEMI criteria, but it was just signs that there was some kind of occlusion. And that's something we can catch in the field, like if somebody's having chest pain and these ACS-like symptoms, do a 12 at the beginning of your call. When you get close to the hospital, run another one. If there's any difference, hey, this might be something more serious.
Right.
Or maybe this is that BS call you thought it was. And, especially where I'm at, where they're so inundated with patients, they triage everybody. They don't care what it is. You're going to the lobby tonight, especially when it gets super busy.
Oh,
this last Labor Day weekend.
Damn.
Yeah, they didn't care what you had. Unless you're a trauma, stroke, you're going to the lobby, son. It was nuts. So
I'm so glad my year wasn't like that. Labor Day was okay, but I feel bad for whoever worked last night.
I was on a 96. It was a long 96.
Damn.
A lot of drunks, a lot of drunk kids, a lot of TCs. It was a busy weekend.
I want to tangent off that real quick for people who are
don't
like
drink and drive.
Well, no, actually, no, more of the fire side of stuff, because I don't know how I got through my EMS career without working a 24, let alone a 48 or 72. But how much sleep are you actually getting on a 96 with a busy holiday weekend?
Oh, geez.
Because I feel like people don't talk about the psychological, or like they don't talk about the bad side. Like when you make it a goal, there's definitely, I feel like there's give and take or sacrifices, right?
So that's a good question. I really think it depends on the person, because I came from 7 years of night shifts. I could go from sleeping to waking up for a call and do it and be just fine. Like I
don't know how you do it, because I'm a narcoleptic. I feel
and run the call. I can be on with the patient, like, oh, hello, dear, how are you? Like the whole thing. And as soon as I get off, done with the call, I am falling asleep in some obscure position in the back of the ambulance. It was 7 years of that, and I was actually pretty good at it. There's another guy at my work. God love him. When he gets a call in the middle of the night, he runs around like he put on his shirt backwards once. He's like, "Did we get a call? Yeah, we got a call. Like we're all in the ambulance, we're all in the engine waiting for you. Like let's go, dude." And he's like, what are we doing right now? Like it's just complete. I honestly don't know if he's awake. Like he might be just sleepwalking. Like it's crazy. So it just depends on the night. Like we were busy during the day, ran a couple calls at night, nothing too crazy. You're getting a few hours of sleep. When you're on probation, which I just finished.
Congratulations.
Thanks, buddy. It's different. Like so, when you're on probation, you don't get to go to bed early. You have to be up first. You have to be on for every call. So your sleeping isn't great. Now that I'm done,
First up, last one
I
to
go
bed,
to bed
right?
at 8 o'clock. I'm in bed at 8 o'clock, like ready to shower, 7:45, and I am in bed snoozing at 8 o'clock. And, I just have a little pager by my bed, and for calls, I wake up. So there's some nights where you run a call, you get back to bed, you lay down, get another call, and then you're just up all night. There's some captains who are pretty nice about it. And even if you're on probation, they're like, hey, you had a shit night, go take a nap. I don't want to see you up before 9 o'clock, or go take at least an hour nap, get yourself together. So it just depends on who you're with, where you're at.
But don't expect that, right? If someone gets hired with whatever department, if you're on probation, if you're on probation, you should be up during normal hours, right? You won't have that.
I would never expect that.
Bleeding heart captain.
Oh yeah, there's don't expect that. So, man, it's just so hit or miss. You might be up for a solid 48 hours. Well, they run a different schedule out in LA, but
right.
It just depends on where you're at. So I used to work a lot. I do work a lot of overtime. We just have a lot of openings in my department. So those 96s are pretty common. Yeah, you're just there's a lot of times where you're up for a day, and then you get a solid nap and you just feel refreshed. But that's me. There's other guys who just are zombies after day one, and if they're working at 96, you just don't talk to them. You just like, do you need some food? Need some water? Coffee? There's plenty of coffee.
Yeah.
And then you just kind of just give them a steady flow of caffeine, and usually they do okay.
I'd probably be that guy.
It's not that bad. I don't know why everybody's such a baby about it.
I'd be like those Cal Fire dudes at the end of a 72 when they're super cranky and need a Snickers bar.
Oh, you mean every single one?
Yeah.
Oh, sweet Jesus. Honestly, one of the biggest things for me is exercising. Like, if I get a nice workout in, I'm up. I'm good. Like, I can work a whole day and feel great. I start getting tired in the evening, and that's fine.
You said you weren't going to do that.
I know. I really didn't want to, but there it is. So, yeah, a workout goes a long way, especially in the fire service. But in the ambulance, there wasn't none of that.
There's
so
no time
just
to
a
work out.
steady stream of bang right into your veins.
Yeah. Bang and Del Taco.
Oh, just the best way to die young.
Yeah, that's true. Actually, I swore off. So, this podcast was supposed to happen a week earlier, but I had food poisoning from probably bad Del Taco. That's probably what happened.
Well, you get what you deserve.
Yeah, I guess so.
So, what do you eat? We're not young men anymore.
No.
Okay? We
So-
can't eat Del Taco.
I don't work a night shift anymore, but working a mid shift from 1500 to 0330 after getting slammed
What
in.
time's that?
Most people, yeah, whatever. I hate you.
I know. I love it.
So just got effed in like the fast track RME part of the ER, which is kind of functions as a urgent care. So it's supposed to be lower acuity, but you're just getting slammed with numbers, right? So I treated myself to some after shift Del Taco, and I'm pretty sure I got food poisoning from that. Yeah.
Well,
So no more Del Taco. That's all I'm gonna say.
do you have that thing where, like, if you get food poisoning from it, anytime you even think about it, you like makes you want to vomit?
It's definitely not making me vomit, but I'm definitely adverse to the brand right now. I am not craving Del Taco for the next year.
I used to love Crab Cooker, Boiling Crab, those kind of restaurants.
Okay.
Like little
Yeah.
bags of shrimp.
What happened?
Not no more.
No, tell me.
Oh, after I had some.
Because I love boiling crab, but
the day
my
before
girlfriend does not like
Thanksgiving,
shrimp.
right?
So
And I went and visited some family, and that night I wake up in the middle of the night and just start puking my brains out all night. And it was that from that fucking boiling crab. And it ruined me. Every time I see it, I used to love it. And now every time I see it, I just like, oh, I hate you. Get a little
Dude, the
turning
morbid,
in my stomach.
yeah,
Ugh, no good.
the morbid EMS guy to me is just like, what was that, all red and just like, oh my god, I'm having a GI bleed. Is this varices? I don't even.
Like, oh god. I know I drink a lot, but not this much.
Yeah.
We can edit that part out.
Guys, give us a break. It's our first episode.
Oh, I know. And I'm not gonna lie, I got solidly buzzed. This whole part would just be like drag, click, delete.
Yeah.
Well, is there anything else you want to talk about? So we kind of talked about imposters. We talked about moving around your typical 12 lead to other parts, posterior, right-sided, checking out other areas of the heart because we are typically just looking at that left anterior portion. What about treatments? What do you guys? So in the EMS system, I mentioned it earlier, but most protocols are typically saying aspirin. Do your 3 sprays of nitro sublingual. You can do nitro paste depending on where you work. I know Orange County doesn't allow it, but Riverside, where I'm at, they allow some nitro paste, just a quick inch. And then something I think important to note is that if you have their pain level down to 0 with your nitro, you don't need to give your morphine.
Yeah.
Some people have that misconception like, oh, Mona, I need to stick to Mona. It's always Mona. So if you get their pain levels down to 0, you're good. You don't have to worry about the morphine anymore.
If it's a true STEMI, I still give them morphine because you're working on that preload or afterload. See, I'm super fucking rusty. Anyways, no, the point was you still give the morphine not for the pain relief, but for how it works on the reduced cardiac workload.
Okay, so
if you have a documented STEMI.
I typically I would get down to 0. I'm like, okay, I'm just gonna go ahead and leave it. I don't want to mess with their blood pressure.
If it's ACS, then yes, but for definitely a STEMI, you continue with your analgesics for the cardiac effect.
Well, there you go.
The other thing, in no particular order, that I learned through the years was, ER physician told me if they're already taking 81 of aspirin every day, just give the aspirin to complete the 324. You don't need to go over 324 because you could overdose them. But I think the threshold for how many milligrams of aspirin a human can have is
super high.
It's super high, but you definitely don't want to go over the 324. At least this is what is kind of accepted by a couple ERs. Because there's a few times as a nurse where if they've already gotten because the physician will always order the 324 on any ACS patient or any patient that's being admitted with a positive troponin. And you know, anybody from EMS or that's working in the ER, it's like you get a radio run, you get the triage report, and then you get another report from the medic, or if the triage nurse cuts the squad loose, you get a third, fourth-hand report from the BLS crew. Mm-hmm. You don't know unless you talk to the patient themselves. If they already got the 324, you don't want to give them another 324 from the ER, so that's a good chance that you could hold it.
Yeah.
Or if they take 81 a day for some other condition, just complete the 324.
So where do you stand on if the patient took their own nitro before you get there?
That one, I haven't actually. It starts again. That's the only thing. I haven't been in that position where.
See, I've always thought if you're not getting any relief from the nitro you took before you got there, I'm going to assume it's bad, and I'm going to give you my own, and I'll give all 3 sprays.
I agree with that. But then we were always told that it always starts when EMS comes in, right? Prior to. But I mean, nitro is short acting, right? So sure. The other thing I want to touch on was like aspirin's like the most important thing. If you suspect it's cardiac related, but none of the usual stuff is working, just give the 324 of aspirin or complete the 324 of aspirin.
I like that. Complete the 324 of aspirin. Whether that's you giving yours or if they took any, you can see how much they took and then complete it.
I've had other colleagues use the nitro as a diagnostic tool as well. They'll give the aspirin. And then they'll give the 1 spray. And if the 1 spray doesn't relieve it, they'll just hold it, considering that
if I'm doing my 12 lead and it comes back normal and I'm not seeing anything and they're having a couple symptoms, I will do my aspirin, 1 spray of nitro, cover my bases, see how they feel after. And if there is relief, I'm like, okay, then I'll give additional sprays. If there's no relief, it might be something else I'm going to worry about.
Right, yeah.
We're going to just bring them in. Yeah, that's pretty standard. Or I think I like that technique.
Mm-hmm. Also, with your nitro paste, if you're in a system that does that, I haven't had a long enough transport time to benefit from it. But nitro paste takes about 15-minute onset on the skin. So if you suspect it's ACS, you put your nitro paste on first, right? Because your nitro sprays would probably go every 5 minutes. So by the time you max out on your protocol 3 nitro sprays, the nitro paste should take effect.
Oh, okay. Yeah, I never even thought about it that way. But
yeah. So you want to get your inch on first because it's a 15-minute onset time, and then in those 15 minutes you give your 3 sprays of nitro.
Well, there you go. I didn't even think about that, but that's simply how I do it. Just like what you're starting your aspirin, some people put on the nitro paste, and then you'll start your nitro once they chew that up. So anybody who's ever worked in EMS, all people have dry ass mouths and it takes them forever to chew up that aspirin. Jesus. That's why I hate nitro tablets. It drives me nuts because they're just like, it's not absorbed yet. I'm like, oh, God,
yeah,
it's gonna take fucking forever.
I will always give my nitro in the ER with a little cup of water.
Really?
Yeah, just because it's like it gets chalky and everyone complains about it. So I was like, I don't know if I can give you water, but I'll give you enough to get that aspirin down.
Spray all day.
Yeah.
I'll take spray all day.
We don't have spray in the ER.
Why not?
I don't know. Depending on the current ER I work at, everything comes from the pharmacy, right? They just give you 1 tablet. Ugh. So you have to go to the Pyxis or Omnicell every time.
Oh yeah, that makes sense.
So whereas other places they just dispense you a full vial like we have it on the rig, and then it's at your discretion every 5 minutes.
That makes sense.
And then you just chart it on the MAR.
So much better.
Yeah.
Oh, so much easier. All right. Any last minute things you want to talk about before we wrap this one up?
I don't think so.
All right. So we hope you guys learned a little something. I know there's a lot of back and forth. Again, this was our first episode. I hope you guys liked it, and hope you enjoy holding the wall.
All right. Huh. Oh shit, my ears hurt.
They hurt. Oh.